All right, it is noon and we will get started with this webinar. Welcome everyone to our Preventing Measles Tools to Protect Our Communities. Happy to see so many able to join today. My name is Mary Lizakowski and I'm a Coalition Health Director with the Foundation for Health in North Dakota. We are a nonprofit organization established in 2022 with a mission to promote health and wellness across North Dakota by working at the community level. Just a couple housekeeping items. Webinar attendees will be automatically muted for the presentation. After the presentation, a link to the recording will be sent out along with the evaluation survey. And if you have questions, please, we welcome you to put them in the chat and we will answer them at the end of the presentation. It is my pleasure to introduce our presenter today, Dr. Kumar, who is a board-certified pediatric hospitalist and specialist in pediatric hospital medicine. Dr. Kumar is a distinguished medical educator with over 30 years of clinical experience in India, the Middle East, and the United States. He has served as a clerkship director and was elected president of the North Dakota Medical Association. His excellence in patient care, medical student teaching, disaster preparedness, and advocacy for child health has earned him national recognition. Additionally, he is a fellow of the American Academy of Pediatrics, and we are so happy to have you joining us to talk to us about measles today, Dr. Kumar. So I will turn it over to you.
Hi, thank you for having me, Mary. And obviously, that picture that you see was taken a few years ago, maybe last year. Okay. Anyway, so we'll get going right away. Um, yes. So these are the topics that we plan to cover. So it's going to be a little fast-paced because it's such an like a huge topic. But I will definitely talk about some clinical manifestations because that's my forte. And of course, we will talk about vaccine guidance and who are the priority. And we'll also talk about what's happening in North Dakota. So, why is 2026 so important for measles? Like, there is a huge surge in measles across the country, including like North Dakota is not spared. Then there are hospitalization, like 36 cases in North Dakota in 7 counties with the 5 hospitalization and unfortunately 1 death. Uh, these are the names of the county. So in the world, we see the darker the color is, the more measles it is. The maximum measles here, as you see in Zimbabwe, and USA still has measles, and this is China and India also a lot of measles. And this is like in across USA, very few states are spared, but it is spreading fast across the country too. And on the last picture, of course, is of our North Dakota. You can see the concentration. We will talk about it more. And of course, all these are available to you in a slide, this set. So you don't have to take notes, just enjoy it. So what is measles? Measles is like a highly contagious disease and there is only one serotype, unlike polio where there are three and RSV, there are multiple. So you have measles like vaccination and measles infection confers lifelong immunity. The causative agent is a morbilliform virus. It is single-stranded, and historically, it has been a very like it was a disease that wiped out like up to 13 to 20% of island if it was introduced if somebody was not immunized. I mean, somebody who got measles. This happened in the Pacific Islanders. Uh, and current status, it is re-emerging because of the declining vaccination worldwide. It's not only US, it's like worldwide. The transmission is airborne and virus remains infectious in the air and on surface for 2 years, which is kind of huge. If you just get out of an elevator with somebody who has measles, the measles will be waiting for you if you come 2 hours later. That is the thing that really worries us a lot about measles. So I'm talking to public health people, so obviously you all know what RO is. Compared, see, influenza is like it can infect only 1 or 2 people, while measles can affect 12 to 18. That's why it's such a big deal in public health. Um, who are at risk? Who are the most vulnerable to measles and its complication? So, of course, children are the most, like 75% of the cases in US so far have been reported in children, especially less than 5 years. Immunocompromised, malnourished, easy to understand. This group, that is the infant less than 12 months, are a little bit more prone after 6 months. They do get maternal antibodies if mother was immunized, so they are less likely to get before 6 months, but between 6 and 12 months, they can catch it. And we don't give the vaccine at 6 months because the mother's antibodies might make the vaccine less effective. But we give that if they are going to travel, we give them, like especially who's going to India or places like that, then it is some protection is better than no protection, but it's not counted. They still need 1 year and the 4 year vaccine. Pregnant women are very prone to measles, and they can have preterm birth, miscarriage, and of course, unvaccinated adults, especially those who got only one dose. Vaccination rates. Let us spend a little bit time on this. We know that I don't have to preach to the choir. It's very distressing for anybody who is in the health and even public that we have seen a big decline in our immunization rates. And if you see here on the top graph is like people who have received more than one MMR dose, but I want to draw your attention to the bottom graph. So what does this 4-3-1-3-3-1-4 mean? So that means you should have had 4 dosages of DTaP vaccine, 3 of polio, 1 of MMR, 3 of Hib, 3 of hepatitis B, 1 of chickenpox, and 4 of Prevnar by 2 years of age. So the North Dakota data is that only 62.5% are immunized. So that is the real data, 62.7. And that is why it is so fearsome. That is why we are having sleepless nights. We are just waiting for it to, like, the bomb to go off. So vaccination rates at a glance. What is herd immunity? Of course, all of you know that to have herd immunity, we need at least 95% of the people to be immunized. In US, the average is like 92%. In North Dakota, one dose is 78%. And 60, almost 79. And as I showed you in the earlier slide, 62.7 for the full series. The immunization rate in the western part of the state are lower, and in the eastern, the immunization rates are a little higher, but there is more outbreaks there because that is where most of the population of the country, of the state is. That's why we see more. And we had a recent outbreak in Pembina. Why are the vaccination rates declining? Of course, most of it, misinformation, mistrust in public health, which is kind of sad. Religious and philosophical exemptions are becoming more and more common. Complacency, younger parents who have not seen measles, even doctors have not seen measles. And we see this big thing called individualization of medicine. Parents read on their own, in their own echo group, in their own social circle or whatever, and they think that their own research, which usually is neither scientific nor accurate. Plus, we can see some barriers in rural and tribal communities: distance, insurance, transportation. We should overcome that. And public health is actually not fighting back, I can say. There is no counter messaging, which might be kind of political, but I think that time has come to public health people like you guys to slowly or maybe quickly adapt social media. And all of you, this generation is really good at doing it. So this is our way of saying, and you can figure out some ways how we want to do that. So how do we improve vaccine uptake? So one strategy that I have found very useful, and my clinicians in my group also attest to it, that instead of saying that, hey, what do you feel, let's about the vaccine, do you think want to discuss, what shot do you want? If we change our verbiage, and Molly Howell, our state health person, like public health, she really prefers this, like we should try and say, hey, your child is due for MMR today. Doctors and nurses are very authoritative figures, and we have very good patient relations. Like I've been here for 25 years. Like the parents who were my kids are having their own kids now. So if something comes from me, they're more likely to trust me or a physician or their nurse. So we want people to, the doctors and nurses, to change their wording to say, hey, your child is due for MMR vaccine today. Uh, Transparency and accuracy. We'd like to be upfront and we tell them the risks of and febrile seizure after getting the measles vaccine. Some parents will counter and say, hey, my kid had a fever and then had a vaccine. Sorry, like had a febrile seizure. That is not caused by the vaccine. That's just anybody who has tendency for febrile seizure can get it with fever. But what I want you to share with the families is that 1 in 1,000 people with measles get encephalitis. I was discussing this with Mary just before it started. My talk today. I have my friend in India who is like a national researcher. She wanted to come on this presentation because she has a 70 case series of encephalitis. It's not a benign complication. People die or have neurological sequelae. Uh, so my message to anybody who is coming in contact with the patients is we like to enforce immunization. We like to have tailored communication. Uh, Handouts are always good, and counter the misinformation. Uh, and we should try to keep our clinics open or have vaccination camps, or like anybody who can't make it to it, we have to make sure that that is not the reason for not getting the shot. And our public health department does a good job about it. Let us talk about the CDC algorithm and some clinical manifestations, differential and complications. Incubation period is about 7 to 21 days. Prodrome is about 2 to 4 days. This is when clinicians are likely to see. And if you have to take one message, it's called 3 C's. That is cough, coryza, conjunctivitis. And it is pretty profound. It's pretty high fever. I grew up in India and I've seen a lot of measles, and it comes in waves. We used to even have a measles ward. It's so you can tell from far everybody's coughing and they look sick and miserable, drainage from their eyes. I'll show you some pictures. Then the rash comes, but interestingly, in the second stage where there is prodrome, if you open their mouth, opposite the upper teeth, in the buccal mucosa or even in the gums, you can see tiny red dots, like they're like grains of sand on a. So that is how you can even predict. The patients and the family get very impressed when I tell them that, hey, you are going to see measles in 2 or 3 days, even before the rash has not come. So we train clinicians to look inside the mouth for Koplik spots. I'll show you a picture. Then the rash comes. This is another thing to remember, that the rash starts on the face or on the hairline, and then it spreads head to toe. This is important to remember. Recovery, rash will fade, fever will break. I will talk about immune amnesia, uh, what it is. So let us look at the rash. So this is like a maculopapular rash. They look and the second one is like pretty close up. Macule means flat, papules means slightly raised. In a dark skin person or like brown skin, you might see a different color, so it's not necessarily pink. And in an adult patient, they get less sick from it, but they can still die from it. Like as I said, 25% of the measles cases are seen in adults. Uh, this is the timeline that we see. We call it the 3 C's, as we remember, like cough, conjunctivitis, and of course, the child is like very sick looking. At coryza, we can see the Koplik spots on the inner buccal mucosa. Then the rash appears, and that is in the day 11 to day 18 of the mm, illness. These are some more pictures. They The one picture on the bottom right where you see the teeth, and you can pay your attention and you can see the tiny grains of sand appearance. This is seen only in measles and it is pathognomonic. That means it's diagnostic. And the thing is that it disappears after the rash appears. Uh, and because it appears like 1 or 2 days before, like we can predict. Rarely it can look like candidiasis or fordyce, but it's very hard to get confused from that. Just see the bottom left, how miserable this child is, conjunctivitis. So my friends and colleagues call me often to tell, hey, if I'm in the hospital building or clinic, can you come and help us out? And usually this is what is a game changer. Like, they are not sick looking, they are laughing and playing, these kids, and their rash has different characteristics. So it is not measles if you don't have the conjunctivitis, which is like pretty severe, especially in the first few days. CDC provided us with a very good algorithm to figure out, uh, like, if patient has cough, conjunctivitis, coryza, then and a maculopapular rash, and there are no vesicles. We'll come back to that vesicle part. That is hallmark of chickenpox. If they don't have that three things, as I said, unlikely. Don't think this is measles. If there is, then look back into the history. If there is an epidemiological risk factor, especially travel or known exposure that happened in Pembina County, or like both, then you suspect and you get into action. You isolate, test, and report. This is a good number to remember. I did personally call this number, so I know they are very helpful, and they will. They have. You don't have to know anything. If you have any confusion, question, call them, and they will answer. And if suppose there are no epidemiological risk factors, then we know that measles being uncommon, it can be possible. Okay. Um, can you still see my slides, Mary?
Yes, yes, I
Good.
can.
Okay, good. So, and if of course there is any doubt, and if somebody is not fully immunized, then you can consider testing like MMR vaccine, especially like less than 21 days. Vaccine has not got chance to kick in. Uh, what is the differential? This is what gets us. This is what is important to know. Like, we do know that every rash is not chickenpox and every rash is not measles. So let us talk about one by one. I will the rash of parvovirus, also called slap cheek disease, and another one that we see is called the sixth disease. We'll talk about that. Then there is like an enterovirus. Everybody has seen that, hand, foot, and mouth disease. Uh, Varicella or chickenpox. Many of you must have seen, but the hallmark is like teardrops. I will show you, and we will talk about rubella, and we will also talk about Kawasaki disease. Rubella is called German measles. So let us see fifth disease. I'm sure many of you must have seen it or gotten it yourself. The hallmark is the lacy rash on the cheek, which is called the slap cheek appearance. And this is usually seen in school age children, and they have mild fever. They're not too sick. If they're older people, they even get arthralgia, that is muscle pain, and rash might be absent, but it is no problem for the kid. It's a problem for whoever is next to the kid. And if the mother or the daycare provider or the teacher is pregnant, then it's an intrauterine infection. That is, if that mother gets it, she will pass it on. Uh, can lead to fetal hydrops, miscarriage. Okay, and we can diagnose this rash whenever in doubt by doing serology. And we also know that a good number of these patients have leukopenia, that is, their white cell count declines. But it's kind of an innocent disease that it does not do much to the patient who is having this condition, unless, of course, they are pregnant. So, Rosella, it's also known as the sixth disease. After five comes the sixth. This is a disease in which we see very high grade fever, 105, 106. And I teach my medical students that this is the where these kids are laughing, playing, eating, drinking, and they, in fact, uh, look well. So this is unlikely to be confused with measles. And these are like pink macules, and they start on the trunk. History, history, history. You ask, how is the rash evolving? It evolves from the scalp and the hairline in measles. Here it starts from the trunk. And uh, just an interesting anecdote, like, if somebody had febrile seizures, this probably is the one that caused it. Not the febrile seizure, but the fever caused by Rosella infantum. It's also called exanthum subitum, and it is also called the sixth disease. And it's a self-limiting condition, benign illness. Hand, foot, and mouth disease. I'm sure everybody must have seen this. It's like rampant in daycare. Bread and butter pediatrics. It's caused by enterovirus, especially Coxsackie A. And we see blisters and on the hands and vesicles on the feet and in the mouth, around the mouth, inside the buccal mucosa. And these children also look good unless they are not drinking and they get dehydrated. Uh, but fever is usually mild and brief, and the rash can sometimes be like urticarial. What it means that it blanches and it's like little larger macule. And remember that the hands and feet are usually spared in measles. So this is another trick we use. So this is hand and foot. That's why it's called HFM, hand, foot, mouth disease. And of course, it is a contagious disease, but again, self-limiting. It's like rites of passage. Everybody gets it, but there's no vaccine for it, and none is needed. So how about chickenpox? So I love this slide because chickenpox tells you that the chickenpox comes in crops. So that means like today there will be a fresh crop, and a few days later there will be another. And the one that you see, which it says ulcer on it, this was the first crop. It has now, like, it's about to be shed, and it will scab and it will completely fall off. At the same time, you see a new papule emerging, and at the same time, you see a mature papule called a blister, which is fluid filled vesicle. And this fluid filled vesicle is actually a hallmark of chickenpox. Again, not very difficult for a clinician to figure this out. So I usually joke with my patients and the learners who want to remember this. I said this is like a family in which the grandfather, mother, and her grandchildren are all living in the same house, because you see a young lesion and an older lesion, and you're also seeing like a dewdrops on a rose petal vesicle season. So what a beautiful description, dewdrops on a rose petal. I'm sure our child is not feeling that love. So fever is usually milder, it's highly contagious, it's vaccine preventable. Some people will measles rash is never vesicular. Remember that. Measles rash is never vesicular. Some parents will tell you, okay, we go to chicken pox parties, we don't believe in the vaccine, we like to have like our kid get chicken pox. We advise them, this scarring can leave, this vesicles and the healing can leave scarring, pigmentation, disfigurement, and about we have many deaths also from chicken pox. So it's not a benign illness, especially if somebody has had organ transplant, immunodeficient, pregnant. It can be a disaster for them. And when in doubt, we can always do a PCR to figure it out. And this rash is also very pruritic. It itches like crazy. So our next one is called the German measles. So it is different from our measles. That is roseola. This is rubella. So don't get confused. Like it comes with the word German attached to it. So like that is how we say. And rubella, Bella. Pay attention to the spelling. So the rash in this is like kind of light pink, and there is lymph nodes that almost always go with it. And I'll show you. It is a very mild condition for a kid. But again, if a pregnant mother gets it, then suppose this lady on the where she has a rash, she gets it, then it is a disaster. Then because it is she passes it on to the fetus, and fetus is born with a syndrome called blueberry muffin syndrome. Their whole body looks like blueberry muffin because the stem cells from the bone marrow migrate to under the skin, and actually they are doing erythropoiesis there. I had a picture, but somehow it is not showing up on here. But if you see the posterior auricular lymph node enlargement, that is kind of a hallmark too. And these kids, as I told you, they don't appear sick, and it's still quite a contagious disease. And we have to avoid contact with pregnant women. And this is the R in the rubella, and in the R in the MMR vaccine. Measles, mumps, and rubella. Mumps is a swelling of the glands, the parotid glands, and sometimes pancreatitis, sometimes like orchitis. But the R is for the German measles. So it's not a serious illness for the infants or the children, but it's a serious illness for pregnant women. That is why we like to vaccinate everybody, so the pregnant lady should not get the MMR, should not get the rubella. If she gets it, fetal demise and complications, including congenital heart disease, aortic stenosis, and cataract, deafness, all this can be seen. In fact, I have one of my nurses who was with me in clinic a long time back. Her daughter had the deafness from this. So this is not an innocent condition if the mother gets it. So this is the rash where I told you it's like more pinkish. They're not so sick appearing. Another differential diagnosis, which actually is not an infection, but we consider because intervention is very important in this, is called the Kawasaki disease. So, what is Kawasaki disease? Kawasaki disease is an autoimmune condition. There is an unknown reason. Nobody is like people are chasing Nobel Prize for this. They don't know what's causing it. No agent uh, is known, and the tongue reminds you of a strawberry. So if you look at it, there is strawberry tongue. This is, and you need like three or four of these characteristics to diagnose it. There is no clinical, there is no lab test. We can only diagnose by what we are seeing. So knowledge is important. So if they have a strawberry tongue, and if you look at the eyes, I mean, if it was a live audience and sitting in front of you, I could have asked one of you, but look closely. You see the eyes are red, but there is no discharge. So that is called non-purulent conjunctivitis. So if you see discharge, then it is not Kawasaki disease. Then you tend to go towards measles if there is conjunctivitis with discharge. Of course, measles will not have strawberry tongue. They will not have the rash on hand and feet. Do you see the rash on the hand and feet? And one thing that happens in Kawasaki is the rash peels off. And then the same autoimmune activity that is taking place all over the body also affects the coronary arteries, believe it or not. So it leads to coronary artery aneurysm. And that is why we have to start high dose immunoglobulin IVIG right away to cause immune paralysis so that we stop the progression of the autoimmune destruction. Then we will look at and they also get lymph nodes. What are the testing recommendation? It is always better to call our health department. They are very responsive. I've been in Bismarck for 25 years. Before that, I was in Fargo. Multiple encounters with the health department. They're extremely helpful people. They'll walk you through everything and isolate right away, in a pressure room if available or in N95. I just read that in Utah, like 2 days ago, like they started isolating like they were doing in COVID times. That's kind of scary, especially in one community, that anybody who comes with a suspected rash is checked in his car. They are not asked to come into the waiting room. The nurse goes out to them and they call the inside, and the nurse can say, hey, this does look like measles. And if she comes and tells the doctor, then the whole system kicks in. If she does not, then feel that it is measles, then the child can be among other kids. So always isolate, 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 because remember that RO was 12, that means 12 people will get infected by one child. There were cases of people passing through airports who getting infected. So what is the way to diagnose it is RT-PCR. You can do it from the nasopharyngeal, that is NP, or oropharyngeal. Nasal is preferred. It's a synthetic tip and with a plastic shaft with a viral transport media. Keep it cool, transport it right away if you're out of town. But if you're in Bismarck, state lab processes it. You don't have to take it to the state lab. You just give it to the lab that you are used to. Like I'm in Sanford, I'll ask Sanford. The sample goes to Sanford and their courier takes it to the state lab and they do RT-PCR. A word about serology. Whenever there is acute infection in the body, any acute infection, IgM goes up. So you can say, hey, that's an indirect measure. And then IgG goes up later and it remains elevated. But kind of strange, the IgM might not go up in the first 72 hours of the rash. So it's not very reliable to do the measles serology. But most of us will do that because it helps us make another diagnosis. But the gold standard is still RT-PCR. Now, because it's a systemic virus, you can probably get it in urine also, but it is accepted. But we still prefer the nasopharyngeal swab. Key word about the serology: if we do the serology, we like to do it again in 3 days, because a negative IgM does not mean that it's not going to be elevated later. As I told you, it might not come in the first 3 days. Uh, and the spelling mistakes, uh, make sure there is not a rubella. Rubella is German measles, and rubella is our measles. Okay, what we are talking about today. And this is a class A reportable condition. So you don't wait for a positive test report result. You just report it right away. Complications of pneumonia. Complications of pneumonia, complications of measles. A lot of people, especially nowadays, they will mention that measles, even officials who are not very well informed, that measles is innocent illness. We say, no, it's not an innocent illness. Like up to 6% can develop pneumonia. The pneumonia can be caused directly by the virus itself. That's called the primary virus, and it causes giant cell formations, destroys the lung, and those giant cells have a very interesting name. They are called Warthin Finkeldy giant cells. That was named after the doctors who diagnosed it. But you have to do a biopsy, of course, it's post-mortem. And secondary bacterial pneumonia is another cause of morbidity and mortality. This one is worth mentioning. SSP is subacute sclerosing panencephalitis. The whole brain is affected. So this is something like um, a dreaded complication. Have you heard of the mad cow disease? Something like that, but of course not the mad cow disease. So what happens in this condition? The measles virus never leaves your body. You get it; it's there. It goes. It's neurotropic. It goes and sits down in the brain cells. And when we are geriatric and or maybe even older, this virus starts destroying the brain, which your own body's immunity, which keeps all this in check, is waning, and invariably fatal. And it can happen even 7 to 10 years, but long later in the life also are present. But this is a dreaded complication, and this is the series that my friend has. Like, she has in India like 70 case series, the largest in the country. I would have invited her to show you some slides and patient things, but time was not enough. Diarrhea and dehydration. When I was in India, when we used to manage, we used to see them being admitted with dehydration because they're so miserable, they can't eat, they used to have diarrhea. And once they were admitted, we could tell from far. Like, we even, it used to come in waves, measles. So I remember we used to open new rooms to put them all in one room together, and we could tell from far because everybody was coughing away and they looked sick and miserable. Encephalitis. So anything itis is inflammation. So encephalitis, inflammation of the brain. So the inflammation of the brain, 1 in 1,000, not rare at all. High mortality, high neurological damage. This is one of the big reasons that we like to immunize. Ear infection, of course, and blindness, especially in Bangladesh and like other African countries, they've reported that if measles will not cause it, but if you have uh, malnourishment, which invariably will happen after measles, I'll tell you why. And then you already had vitamin A deficiency, you have diminished immunity, then you get corneal ulceration, and it is a leading cause of childhood blindness. So measles is the leading cause of childhood blindness indirectly. This is what scares most doctors and scientists. Very, very important slide. And that is why you should stand your ground. And if somebody says measles is an innocent condition, show them this slide. It selectively goes and takes out the memory of your B and T cells. So B and T cells, which are like going to be protecting your body, it selectively affects them. In countries where tuberculosis is rampant, they get tuberculosis. That was a reason that in India we used to see India has like very high tuberculosis. So we used to see this, that there was invariably, it would like either patient had latent tuberculosis, or if they get exposed, they will get it because they are defenseless. So look on the right side, after measles, up to 70% of the memory cells of our immune system are lost. Okay. So, and this can stay on for longer. So there is a second spike in mortality, and vaccination preserves all immune memory. So that is important. It's extensively researched, and that is so good to know. Who are the people who should be getting the vaccine the most? You know, so first MMR dose is given around 6 to 11 months if you are going to be traveling. If you remember, the mother, if she is immunized, she will transfer the placental antibodies, which are good for the first 6 months. So if you give the vaccine before 6 months, it's a live vaccine. Mother's antibodies will destroy the vaccine. No good vaccine. So between 6 and 12 months, when he would have got the first vaccine at 12 months of age. So why do we want to give him now? Because there will be at least some benefit, some protection, which can save the child's life. And most of the doctors who are like around like 15 or 20% of doctors in North Dakota are from India or from measles susceptible country. They come invariably to us to get the vaccine. This is the commonest questions I get asked from my co-workers and other doctors, is like what to do if we are traveling to India or traveling abroad or even to South America or even going on vacation where there is more measles. And I showed you a map of measles. Measles is everywhere. So we say, hey, at least take a vaccine, which will get more effective every month. And by 12 months, maternal antibodies are lost. So the vaccine can be safely given and it will take hold. And remember, MMR vaccine is a live vaccine. Uh, when do we give the second dose? We give the at MMR vaccine is given between 4 and 6 years. They are eligible right after 4 years. We call it kindergarten shots because most parents remember it then, and not later than 6 years. And look at the success rate, so impressive, 97% effective. You know, what about adolescents? When you have any health encounter, they come for sports physical. They are going to go to dorms and they are going to go to college. They're going to travel. So we want to verify two dose series. What about people who were born after 1957? We need to make sure that they have at least two documented dosages because this vaccine came out in 1962, you know. So, or they have the serological immunity. What about the healthcare workers? Healthcare workers definitely need two dosages or a positive serology, regardless of the birth year. Important to remember. And I think I did spend some time between while talking about what to do during time of travel, what to do during outbreaks, especially if the infant is between 6 and 11 months, then we give them the travel dose. Medical comorbidities and increasing risk. Who are the ones who can die? And these are the ones who will probably not be able to get the vaccine anyway. So they are dependent on the goodwill of other people in the community. So getting vaccination also shows that you care. You know, I've had families, which is kind of sad. They don't want the vaccine, but when their grandfather or grandmother, especially if she takes provides childcare to the family, they immediately run to you and get the vaccine. You know, because they don't want grandma to get the mm, illness, especially if she is on immunosuppressants, organ transplant, kidney transplant, especially. Uh, HIV and AIDS patient cannot receive the MMR vaccine. So this is the vaccine. The measles is worse in them. Cancer, measles is really worse in them. Peds hemato-oncologists are so scared of a measles patient. Like last year, we had a scare. It was not measles, of course. Then our pediatric hemo-oncologist said, "Hey, we worked so hard in saving these patients. We got them bone marrow transplant, and all that stuff. And now somebody in their school, daycare, wherever, or in their home, believes more in ideology than science, and then get it, and now you lose this patient. And congenital immune deficiency, especially uh, combined immune deficiency, severe SCID or DJOR syndrome also, they have zero immunity. They can't get the vaccine. If they are exposed to measles, they will have a bad outcome. How about steroids? Patients who have asthma, especially when they get steroids, we like to wait at least 2 weeks before starting the vaccination, because the steroids also prevent the vaccine from taking hold. In India, I remember very clearly, like we gave vitamin A to everybody who got measles, even if they were not vitamin A deficient. What about pregnancy? Pregnant women getting measles is very serious too, but she can't get the vaccine. So but why do we test? We check for MMR efficacy because we check for the measles part, and we also check for the rubella part. Rubella is that German measles. Remember, if the mother gets German measles, the fetus will have very serious outcome, like we call it the triad of cataract, deafness, congenital heart disease, and of course they can have that blueberry muffin syndrome, and they can even die. So how about uh, herd immunity is a good argument to give to somebody who is like pushing back. Uh, I am laying special uh, thing on pregnancy because we get uh, asked a lot. In fact, I'm doing this presentation from the fifth floor of the hospital where the babies being delivered. I saw 11 babies this morning today. So I looked at their MMR vaccine status of the mother, and they say, hey, MMR is immune, rubella immune. So rubella is the one, R is for the German measles. And unfortunately or fortunately, the MMR vaccine is a composite vaccine. We don't have individual vaccine licensed in US, though in Europe it is. So the MMR vaccine cannot be given in pregnancy because it's a live vaccine. Um, Measles can lead to miscarriage, low birth weight. There is no intrauterine transmission. So we are lucky here that, like syphilis and HIV, where the mother can give it to the baby across the placenta, it does not cross the placenta. If the baby is exposed, obviously the baby cannot get the vaccine. So we give them the passive vaccine, which is an immunoglobulin. And I cannot stress enough how important it is to screen all women of childbearing age for MMR immunity. But remember, the R here is the German measles. We are more worried about German measles when we talk about MMR in pregnancy. And as a rule, anybody who is willing, and we see that their rubella antibody titers are not good, we call it rubella non-immune. We give them the vaccine before they leave the hospital with the baby, so that the mother in her next pregnancy is safe. And whenever we give the vaccine, we like at least to wait for 4 weeks. Um, Vaccine guidance. So, as I told you, measles vaccine is not available. It's only one like component of it. Whenever we use it in a combined vaccine. These are the three big ones. The uh, Praorix was recently in 2022, and the MMR2 and ProQuad is also used with the age limitations. If you go to a clinic, just pick it up and see. And ACIP recommends the ProQuad between 12 months and 24 and 12 years. Uh, what about this vaccine? This is the one vaccine that has like got the maximum hostility all over the world. It started off by a doctor who was aligned with the like who had self-interest, and who reported few cases of isolating the MMR viruses in the gut of these kids. And he said, oh, and cause and effect was established. But subsequently, we proved it that there is no autism related to MMR vaccine. I'll come back to it again. But MMR vaccine is, as we discussed, very effective. Two dosages are 97% effective. One dose is 93%. Duration for life, licensed in 1971. And it is a live attenuated vaccine given subcutaneously. When you make it quad, Q as like four, that means you added the V for varicella or chickenpox. So M is measles, mumps, Rubella is German measles, Rubella, and this is the chicken pox. Um, Serious adverse reactions are rare. Like I have seen so many patients. In fact, like I've practiced medicine from 40 years on three different continents, and I've never seen one. So like so rare. Common side effects like with any vaccine or shot, you can have soreness, you can have some mild rash, maybe suddenly the fever goes up, you can have a febrile seizure, but there are usually no sequelae. Uh, what about encephalitis? You might make a case that the virus, if it is live, can cause, even if it is attenuated, it can cause encephalitis because it is known, wild virus is known to cause encephalitis, but the incidence is less than 1 per million. So it is like, in fact, I don't think even a single case is reported in the US, but you might have to check that. As against somebody who is getting the measles and was unimmunized, 1 in 1,000 chance, which we know is a pretty good number. So, what are the routine dosages that we give them at between 12 and 15 months? And second dose is given between 4 and 6 years. Catch up can be done anytime, but you need to do two dosages. We discussed about travel, we discussed about outbreak, which is same as travel. You know, in HIV, it depends if you have good CD4 counts, maybe you can get it. Uh, and healthcare workers need two dosages 1 month apart. We don't need to do blood test, expensive, stick a needle. Extra, whenever there is a doubt, extra MMR dose is best. So um, how about North Dakota specific outbreak guidance? Dunn County, there is no community transmission. Pembina outbreak was declared over by April 15th. We recommend standard recommendations, routine between 12 and 15 months first dose, second in 4 and 6. Repetition helps in memorization. If suspect, call the number, and of course, you can get more information as you need. What do you do? I mean, you guys are like from public health. So what do we do if there is a known confirmed exposure? So immediately within 72 hours, we like to give the unvaccinated people, if they are more than 6 months old, it will prevent or even attenuate the disease. If they are within 6 days, we can probably give immunoglobulin, and we do that, especially if infant is less than 6 months old, can't get the vaccine, and pregnant women don't have any immunity, if suppose, then we need to give the immunoglobulin. Quarantining the unvaccinated people for 21 days. Imagine the loss of work. They say like $500 million is being lost currently in 2025 because the mothers couldn't go to work, which is very, very serious for the economy too. And I'll show you one more financial number. Uh, and we want healthcare workers to be immunized. Tracing the exposures is important. Okay. So, what are the true contraindications to MMR vaccine? This is another question we get asked. Is only one is like anaphylaxis and pregnancy, and of course, if you're totally immunodeficient and if you recently had some blood products. Some precautions you have to take care. You should not be very sick. You should not be on steroids. If you have history of low platelets, we try to figure it out whether to give it or not. And about febrile seizures, we like to counsel but not withhold. We tell the parents that if you don't get the vaccine, if you get measles, there is 1 in 1,000 chance. Otherwise, there is 1 in 1 million. Less than that. Big question. Does MMR cause autism? No. No, 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 million times. So as I told you, this Andrew Wakefield was the one that 1998. All the studies. Lancet published it. That was so sad, and there was completely. It was malpractice, wrong study size, sample size, wrong conclusions. What do you do? So if the mother tells you, hey, my child is healthy, do they really need this? We tell them, yes, measles is dangerous even in healthy children. And of course, you can contribute to herd immunity and prevent grandma from getting sick. How about, can vaccine be given when you have measles? No, you cannot give the vaccine. Oh, sorry. Can the vaccine give my measles? Can give measles to the child? Unlikely. Never. Live attenuated virus vaccines do not cause disease. And even if you get little rash after the vaccine, so that rash is not contagious. So the vaccine virus strain does not cause the illness. Is natural immunity better? This is another common question we get asked. We say, see, look at it. Natural immunity comes at a cost. You might be lucky, but if you are not lucky, you will probably get encephalitis and complication of pneumonia, complication of long-term neurological damage, malnutrition, immunosuppression, other diseases getting active. That's why health department is so serious about measles vaccine. Uh, so what is you guys are on the front line of vaccine advocacy. So recognize the disease early, counsel every visit. You are community leaders. Go and talk to the school people, especially you are recognized in the community, and you are a trusted voice against misinformation. All of us undersell ourselves, but parents look up to us. The society looks up to us. So it is our responsibility. Report promptly, manage complication, and we discussed about post exposure prophylaxis. Another question people will ask, like, how did this react autism link come about? So one of the things was that first word that a child starts speaking is between 12 to 15 months, or around that time. That is when we check for autism, or they'll say mama, dada, maybe around 10, 11 months. But the language testing and development takes place around a year. So this vaccine is given around that year. So if parents started attributing it to this vaccine, the parents were not well informed. It's like saying, hey, I slipped and fell, or maybe I dropped the child. Maybe it's because of the vaccine I dropped the child. So it is a temporal relationship, not a causative relationship. So last but not least, the key takeaways, there are 36 cases. It is alarming for the population that we have. 7 counties, we have like lower than national coverage for our MMR vaccine, which is far, far below herd immunity. So if we are likely to get it, use the CDC algorithm, which is in this slide on the Google to report and uh, find out uh, like how can you motivate, train yourself, ask your friends, ask your teachers, like how do I motivate people who are uh, hesitant for the vaccine. And two dosages of MMR vaccine given at 12 months and at kindergarten between 4 and 6 are 97% effective. So, the coming to the end of the talk, these are the resources, all authoritative. You probably know that the AAP Red Book, American Academy of Pediatrics, is about our infectious diseases only. That's our Bible. Um, so we use that for the best recommendation. A lot of this preparation, I use the CDC Measles toolkit. Very simple, very easy to use, and like I just put your foot in the door and you can like go and explore this, because what the mind does not know, the eye don't see. I'm glad you guys came here. So in case there is some exposure or doubt, you can always like you always know about it, and your brain like works better, and you are able to recognize and do your part. So I'll definitely like to acknowledge Molly Howell, who helped me prepare this, and she's a good friend too. And of course, Mary, for inviting me, giving me this opportunities. You can like even put my cell number there if you want to talk, if you want to ask about. I don't care even if you text me, about your own children or something. Like, let's keep it to measles at the moment. So unless you take me for a beer or something, then you can ask me about other problems in your kids too. But mm, uh, communication is everything. If there is anything that you want to know more about, I'll be very happy. So Mary, we would like to turn over for any questions. You can probably read out.
Yeah.
I don't know where it shows up.
Yes. Let's turn it over for questions. If you would like to stop sharing, I can get my screen back up here. And let me see here. Move to the next one here. Okay. Well, thank you for that great presentation, Dr. Kumar. Um, I I was particularly interested in the fifth disease because I had never seen that before, and all three of my kids got that like 3 months ago, and I was like, "What is this?" So I really appreciated you adding some information on that because my brain went to like, well, they're all vaccinated, but like, is it measles? Even though I knew it wasn't. But it's just kind of crazy when you see
Yeah, it's a
something all over
completely
my skin.
different innocent illness for the child, but for anybody around them and they are pregnant, and if they get this illness, then there are serious implications for the baby.
Yeah, I had no idea. So that
Mhm.
was informative for me. Let's see. I don't see any questions coming in here. I did have one, and let's see. Will someone speak on the legal actions that may need to be carried out by local communities, regarding non-compliance, with I and Q orders? I don't know. I know exactly what that question is. Do
I
you,
and
Doctor?
you, no, I didn't get it. Question.
What was that? I couldn't hear you.
I did not understand the question. INQ, what is that?
Yeah,
Legal
let me put
implications impossible to, like. I mean, just guessing. You cannot force anybody to get the vaccine. And what do you do about somebody who is refusing public health measures? I think you should ask Mary Lizowski. Like, she's probably more informed than me.
Yeah, so
You
it's
know,
the
the public health
isolation and
people protect.
quarantine orders. Oh, thank you, Rachel. Um, the isolation and quarantine order. So
Yeah, so I
that's
almost guessed that. So I would say, like, this question should be addressed to your preceptors and your friends in the who are like MPH. So they probably will be able to answer better.
sure.
We
Okay.
definitely don't want a repeat of COVID, because we know there is big financial implications of the drop in vaccination. 2 days ago, there was a big report on NBC about the measles and financial cost. Every 1% drop in the immunization of measles is leading to 1.5 billion extra expenditure. Why? Because even if there is a small, tiny case, like this was very apparent in Texas, somebody wrote a very nice, like a small, like a podcast over it. I was listening, I recorded a podcast. The entire public health system has to be activated. All of you will be put to work. It's like back-breaking work. And it's like more than the clinicians. Public health kicks in. It's very expensive than the hospital beds. And if they are most people, if they don't have insurance and they get measles, then the hospitals eat up the cost.
Hmm.
And if the kid gets the illness, then parents miss the work. And that number, we had $500 million last year from measles parents missing work. 21 days. It's not a COVID 3 or 5 day or 10 days. 21 days. Like,
Yeah.
your whole yearly vacation is gone. And then
Hmm.
taking care of the kids who have complications like pneumonia, 1 in 10, like encephalitis, 1 in 1,000, long term panencephalitis. So it's not an innocent illness at all. So I'm so glad that I got this opportunity to talk about this, because I'm passionate about this
Hmm.
condition for somebody who has seen and managed measles in India, not in Bismarck. Mhm.
Yeah. Yes. Any other questions? We just have like probably we have time for maybe one more if anyone has anything that they want to put in the chat. I don't see any right now, but thank you for that question that came in. Um, this is really informative, so I really appreciate it. I think it's timely, and really thank you for partnering with us, Dr. Kumar. Um, really appreciate that. Doesn't look like any other questions are coming in, but we will send out all this information to all the attendees and the recordings so everyone can review this and always follow up with questions if they need. Um, so that's great. So we do have the QR code up here for the evaluation survey. If you could take that. Oh, yes. Christy Jensen said, thank you, Dr. Kumar. So, so that's wonderful. Um, and again, yeah, thanks to all who could attend and Dr. Kumar. You
And
can
if you
stay.
are having any questions later on, also, you should feel free to call me. So.
Yeah, Would you like us to, in the follow-up, put your information?
Absolutely. Yeah.
Okay, we can
I
definitely do
mean,
that.
you all are colleagues, and like medicine is teamwork, and public health is a
Yes.
very, very important part of. In fact, I personally feel that public health has more impact on what I have as a clinician. I maybe will probably help like few hundreds, thousands, maybe. You guys help millions.
Mhm.
So
Yeah. Oh, I love that. Okay, so we will include your information. And to stay connected with us, you can follow Healthy Nodak on Facebook, Instagram, Twitter, and Foundation for Healthy North Dakota on LinkedIn. And join the coalition to see what future webinars we might have. So stay connected with us. And again, take that survey. We would love your feedback. And that's it for today. We're at 1, so appreciate it. And have a good day, everyone.
thank you. Have a nice weekend.
Yeah, you too.
I'm leaving now. Is it okay?